Morning. Thank you for the opportunity to be speaking today. I'm going to be talking about the bane of our existence in SFA disease currently, optimizing luminal gain and severely calcified fempop disease. So the challenges in calcifications in SFA and popliteal disease really remain a significant barrier to optimizing vessel preparation, primarily due to the difficulty in obtaining optimal luminal gain, and as well, it's an independent predictor of lesion treatment failure, especially for DCBs. There's actually some data about this published in 2014. Finelli looked at 60 patients with SFA stenosis or occlusion treated with DCB and classified the amount of calcification and found at 1 year there was a significant difference in primary patency, indicating what we already knew, that this is a huge problem in penetration for drug-coated technologies. The barrier to optimal vessel preparation includes causing dissections, perforations, vessel recoil, embolization, and stent crush, which really means that we need to optimize our luminal gain prior to any technology that we're going to be using for the SFA. The majority of our technologies are atherectomy devices, and I think I have included a reasonable list of the current ones available. In terms of directional atherectomy, there is actually some data regarding that in conjunction with DCBs, and that's with the definitive AR trial. The third arm of that trial was non-randomized, looking at a directional atherectomy with DCB for severely calcified lesions. It did show that the procedural results were improved, including a better technical success rate, fewer bailout stents, and fewer flow-limiting dissections, with a trend towards increased patency in long lesion lengths and severely calcified vessels. Orbital atherectomy is another technology that's been utilized to treat severely calcified disease. There's an offset crown that modifies calcified plaque. It provides some debulking and increased compliance of the vessel. I have a patient here. I'm going to present a 75-year-old woman, former smoker with severe short-distance claudication. Her angiogram showed eccentric calcifications of the common femoral, SFA, and popliteal. I was able to cross the lesion true lumen with a support catheter and 014 wire. Subsequently, with the majority of these calcified vessels, I use embolic protection, so I delivered an embolic protection device. And after that was deployed, I utilized orbital atherectomy throughout the entire segment, starting from the common femoral through the SFA and popliteal artery. After that, I angioplastied with a 5mm balloon. There was no flow-limiting dissection, likely secondary to the use of atherectomy, and I was able to DCB this without any bailout stenting. She had a palpable pulse at the end of the procedure. She's about 1 year follow-up with no need for secondary interventions. The data supporting the use of orbital atherectomy is from the Calcium 360 randomized pilot trial, which showed an improved procedural success rate for orbital atherectomy over POBA alone, with decreased bailout stenting, and 1 year freedom from TLR improved over POBA alone. My second case is a 78-year-old male with rest pain. He had severely calcified popliteal arteries. Angiography revealed patent inflow. His initial popliteal run showed severely calcified disease with an occlusion at the pop and reconstitution. The occlusion was crossed, an embolic filter was placed. I used laser atherectomy for this particular case. Post-atherectomy run showed a patent vessel with significant extravasation. I held up an occlusion balloon for 5 minutes for tamponade. The balloon was deflated. There was no extravasation, but there was a focal dissection. I placed my angioplasty, this again, I placed a Supera stent after utilizing a drug-coated balloon. Patient had patent runoff, palpable pedal pulse at the end of the case. So this clearly displays all of the pitfalls with treating these severely calcified vessel. The vessel was occluded. Luckily, everything was contained in the embolic protection device, and this is the calcification that was retrieved prior to completion of the case. There are also some novel angioplasty balloons that are being used to improve compliance in calcified vessel, the Serenator, as well as scoring balloon angioplasty with technically good results. The final technology that I want to discuss is intravascular lithotripsy, which is increasingly what I'm using in my practice for severely calcified vessels. As we all know, this has been used for 30+ years for kidney stone treatment, and we have recently appropriated that for technology in the vascular system. This comes in multiple size balloons, including tibial, SFA, iliac, coronary. The case presentation here is a heavily calcified vessel in a patient, an 80-year-old patient with tissue loss who is not a candidate for bypass. And despite the severe calcification throughout the entire SFA with long segment, I opted to use cross the lesion and utilize shockwave technology. So after performing this, I was able to stent this entire segment with adequate luminal gain to achieve a palpable pulse at case completion. His tissue loss has resolved, and he has a palpable pulse at 1-year follow-up. There is some data to support this as well, the Disrupt PAD3 trial. The short-term 30-day results show improved procedural success with decreased need for bailout stenting and decreased dissection. The longer-term data is also promising with an improved primary patency rate at 2 years, significantly greater with IVL. So in summary, calcium remains a huge barrier to our vessel preparation techniques. We're pushing the boundaries of the devices that we already have on the market. We have multiple options, including atherectomy, specialty balloons, and intravascular lithotripsy. More data is really needed regarding which debulking device is safest and most effective. Should we be using combination therapy, and do we have an ideal protection device? Hopefully these are answers we'll have in the near future, but in the meantime, I think we have a lot of devices in our armamentarium. Thank you.